averaging about 180 over 110. She's becoming more short of breath for an ambulation, could not sleep in bed, and has gained 5 pounds since yesterday morning. Is this systolic or diastolic heart failure?
Yeah.
Why diastolic?
Increase.
Because the fluid is backing up and he's gaining 5 pounds in 1 day.
Okay, and that could also be true for systolic.
Increased blood pressure?
BP often, but you're right on, it is diastolic, but it's probably because of the high blood pressure. She may have a chronic issue, it's caused the muscle to get burned. Cool. What lifestyle question would you ask over the phone?
What you had to eat in the last day or two.
Yeah. Miss McClure is a very nice lady, but she's about 85, and she just talks. And sometimes she forgets what she talks about. What would be another good question to ask?
Taking your
meds.
Meds, yeah. So what do you think that doctor may do if the patient presented to the office?
Admit her.
Hopefully, maybe. But maybe what do you think they might do before?
It might be an ideal situation to have blister packs or have home health go in to pour her meds or give her meds.
He may give her an extra dose of Lasix, maybe tell her to double the Lasix that day for her. So those would be some realistic things. Now we covered a lot in an hour, and I appreciate you guys being so in tune to it. And do you have any questions?
The one question I have is, what if you obviously have a patient who's got CHF and you start talking to them about making choices and what they have to eat and everything, how do you answer it when they say, well, none of that stuff tastes good?
Yeah.
It doesn't taste like the stuff I usually eat.
So I always ask, well, what does taste good? What do you like? And let's talk about that. So, well, I only like cheeseburgers and things. I go, well, okay. And then I put it on them. I go, well, that's totally fine. I always say to patients, I go, you're an adult. You worked really hard in life. You can make your own choices. But what I want you to understand is your choices are going to get you back in this hospital. And if you're okay coming back to the hospital every 3 or 30 days, then don't make any changes. But by just changing one thing here, I can keep you out of the hospital. You can be at home. And I put it on them. You know, my job's not to solve their problems. My job's to get them to understand this isn't worth coming back. Motivating them to make the change. So always say, well, what makes it? Well, if you don't want to give up your ham, would you buy low sodium ham? Or I won't give up my, someone said to me, I won't give up this. I go, okay, don't give up this, but don't have this for breakfast to offset it. And that's how you work with them.
A lot of times we'll talk to patients about like other ways to add flavor besides salt, like different herbs or garlic, and you can buy dried herbs at the dollar store. Like they may not be the best quality, but like something that's affordable and realistic for them.
Mrs. Dash, 32 different flavors. It's great. We really don't recommend Morton's no salt, just because it's has a lot of potassium, and heart failure patients can often be put on spirulactone, and that would be a bad story.
What is the difference between the Mrs. Dash and salt?
It is mostly a pepper-based substitute, so there is no salt in it, it's pepper. So a key thing to say to a patient is when you close your eyes and you open your Mrs. Dash and you pour it on your food and you take a bite of it, don't imagine it to taste like salt. Imagine it to add flavor to your food. Because if they're thinking it's going to taste like salt, they're going to hate it. It's a flavor enhancer or food enhancer, but it's not salt.
I have a question.
Yeah, please.
So for a lot of the patients that we deal with are geriatric patients, and some of them might be 85 years old. Where do you know where the line is between, you don't say that person's having buildup of fluid at home and they call you and they are nervous about their fluid gain. You don't want them to come into the hospital every time they're having an issue. So I just don't know, at what point do you know for that? I know every patient's different, but at what point do you know that they should probably come in and see someone?
So doing this job, because now we do follow-up phone calls, I've had a great appreciation for outpatient nurses and how critical that moment is on the phone when that patient's telling you something and how to respond to it. That's a difficult question because not everybody always needs to come in, but some people do. You have to look at the symptoms, what's going on, how much weight have they gained, what is the program, what type of patient is. Use your team members, your cardiologists, to really use them as a resource to do it. Because to your point, not everybody has to come in. Oftentimes patients get an extra dose of Lasix, we follow up the next day. If things have got better, then we do it again. If they haven't, then we bring them in. Yeah.
Thank you.
Yeah, it's very gray answer to a good question, so. Yeah. Cool.
Cool.
Well, I appreciate your time, guys.
Thank
you.
you.
That's awesome.
Thank you.
Thank you. Thanks, Donna, that was great.